Thank you for joining us today, and welcome back to the AI for Women's Health online meeting. So this is our first meeting this year. We've been doing this for 3 years now, and we're very lucky to have great speakers today. So I'll start by introducing Jen and Kristofer, and our third speaker will join very soon. So today, Jen and Kristofer are going to talk about the use of machine learning in gynecological imaging. Dr. Jen Barcroft is a clinical research fellow at Imperial College London and a specialist obstetrics and gynecology registrar based at Imperial College Healthcare NHS Trust with clinical interest in gynecological ultrasound and reproductive medicine. She has a PhD from Imperial College London exploring the applications of machine learning within gynecology diagnostics to facilitate early diagnosis. Her current research is focused on the development of machine learning-based models to improve the accessibility of high-quality ultrasound imaging and support the classification of gynecology pathology. And Kristofer, let me take my breath. Dr. Kristofer Linton-Reid is an Eric and Wendy Schmidt Science Fellow at Imperial College London, where his research focuses on the development and clinical translation of artificial intelligence for medical imaging across obstetrics, fertility, and gynecology. His work sits at the intersection of machine learning, radiomics, and multimodal clinical data, with the goal of improving early diagnosis, risk stratification, and clinical decision support in women's health. He holds a PhD from Imperial College London, where his doctoral research advanced end-to-end AI pipelines for image-based disease phenotyping, spanning automated segmentation, deep learning feature extraction, and prognostic modeling. Building on this foundation, his current research places a strong emphasis on foundation models and self-supervised learning, developing large-scale, label-efficient representations for medical images that can be transferred across tasks, modalities, and clinical settings. This includes leveraging contrastive and generative self-supervised approaches to learn robust imaging features from unlabeled ultrasound, CT, and MRI data, reducing reliance on expert annotation and enabling scalable deployment. Through his fellowship and collaborative work with clinicians and academic partners, Dr. Linton-Reid is focused on bridging methodological innovation and real-world clinical impact, accelerating the adoption of trustworthy, foundation model-driven AI systems in obstetrics, fertility, and gynecological imaging. And without further ado, I'll let the speakers introduce the talk. Thank you.
That's great. Thank you, Bianca. So today we'll be talking about a few of our pieces of work focused on AI machine learning in gynecological imaging. So the plan for today is I'll give a brief background into what radiomics is and deep learning so that we're all on the same page. And then I'll discuss one of our more recent studies on ovarian cancer prognosis from preoperative CT scans. And then Jen will talk a bit more about our work on adnexal mass prediction from transvaginal ultrasounds. Then lastly, Jen will also talk about radiomics in pregnancy. So the way we tend to work with these studies is we break it down into two components. The first being deep learning and radiomics, and then end-to-end deep learning alone. And what I mean by deep learning and radiomics is often when we're looking at a scan, we want to identify, first of all, the region of interest. So that, in this case, could be an ovarian cancer or an adnexal mass. And probably one of the more frequent ways to build these models is through a convolutional neural network. Perhaps one of the most widely cited papers within biomedical imaging and deep learning is the UNet paper. So the way this works is often an expert like Jen would essentially annotate the image and draw around the region of interest. And once we've collected enough data of the scans in the regions of interest, we'll then be able to build these deep learning algorithms such as the UNet to essentially automate that part of identifying the region of interest. And then one of the ways that we actually determine if the model works in terms of annotating these ROIs is through a metric called the DICE score, where essentially you're looking at the overlap between what the model is predicting as the region of interest and the real life annotations by the experts. Then once we have these ROIs, we can then start to look to extracting some features from them, what we call radiomics. Essentially, that covers a number of kind of classical mathematical features. So you can look at your kind of first order statistics. These are things like your mean, median, variance of the pixel intensities within the ROI. And we can also start to take out sort of shape features. These can be sort of how circular the mass is or how irregular the shape is, etc. And in addition to that, there are sort of higher order features, and that's when you put sort of filters on top of the image. These can be called wavelet transforms or fractal transforms. But ultimately, what we end up with is this sort of tabular matrix of data that we can call radiomics features. With this tabular data, we then feed that into our machine learning model development. Here, you can downstream tasks could be, for instance, determining if it's benign versus malignant, or it could be other tasks such as overall survival or subtyping. The tiny kind of classical machine learning models are employed. These can contain like your linear models, like your logistic regression, your random forests, or more complex models like classic neural nets. Within this workflow, we tend to do things like your cross-validation, hyperparameter optimization, etc., just to get the best model possible. Alternatively to this sort of radiomics pipeline is just going directly end-to-end with deep learning. Often in this case, you don't necessarily need to have the segmented region of interest. You can do it with the segmented region of interest, but you don't necessarily need that in the first place. Often what people try to do is get it directly end to end without having to have that initial manual inspection of the data to get those annotations. Generally, probably before 2020, convolutional neural networks were really the key player in terms of deep learning architectures, whereby increasingly deep these convolutional neural networks are, the more higher level features you'd extract. And ultimately, you're doing that again, the end-to-end predictions. These could be classification or sort of prognostication. These days, as I mentioned, pre-2020, it was really convolutional neural networks, but you can also replace the CNN with sort of a vision transformer or more and more complicated architectures. So one of the studies that we've got coming out in the next week, which is quite exciting, is a study that used basically pre-surgical CT scans to identify and predict prognosis. Going back to that framework that we previously had of the segmentation model followed by radiomics, we developed what was like UNet-like architecture via the package non-U unit, which I highly recommend, as it generally performs very, very well. And we basically automated this segmentation task on the CT scans of getting the primary ovarian cancer masses. You can see on the right-hand side the number of data sets that we're working with. So we had Hammersmith Hospital dataset training and validation, a TCIA, the Cancer Imaging Archive, which is a great resource. We had some external test data from there, and we also had an additional external test set from Essen. The DICE scores generally performed pretty well, with the lowest being 0.81. In this middle panel, I've got an example of what the average example looked like. So you can see in the purple what the radiologist annotation was like. And if you look closely, there's a red just behind that purple. That's exactly what the model was prediction, but it was also capturing a sort of bilateral lesion as well. So that was the average predictive performance. And then once we had these ovarian masses segmented, we then looked into building our radiomics models. We also tried this end to end, but often for prognosis, I tend to find classical models tend to work better, like your Cox proportional hazard model. But within this, Essentially, we're employing a number of different feature reduction techniques on your tabular data and various different modeling techniques on top of those reduced features. So on the x-axis of this heat map on the left-hand side is the various different feature reduction techniques. And then on the y-axis, that's the various different models. So you've got things like your random survival forest, your Cox proportional hazard model, regularized different Cox proportional hazard models, and other different boosted gradient, boosted tree models. And from there, what we found was our best model on the training set was this a random survival forest model, giving us a concordance index of 0.72. And then once we had these predicted probabilities from the model, we then tried to stratify them into high and low risk cohorts. This is an example on the TCIA test set where we were able to stratify them into this high and low risk cohort, just using classical k-means clustering of the predicted thresholds. And then we were able to follow this up with some omics data that we had. We had some transcriptomics data. And with this, we were able to identify, first of all, genes that were highly correlated with the high risk individuals. And then we were also able to look at KEGG pathways and identify a number of pathways that were really quite important. Sort of key players, we did identify the kind of usual suspects like P53 signaling pathway, the snare interactions, MAP kinase signaling pathway being activated as well. And then we had a few other sort of maybe irregular ideas, but if you look in the paper, we've got some theories as to why these are things like hemobiasis and stuff like that that you wouldn't really initially expect to be related to cancer, but we suspect it might be following a potentially similar pathway. So yeah, do look out for this. It's in print and will be coming out within the next week or two in Lancet Digital Health. So with that said, over to Jen to talk more about our work on ultrasounds and adnexal masses.
Thanks, Chris. So, as Chris said, I'm going to talk a little bit about how radiomics fits into the ultrasound diagnostic pipeline. And Chris has talked really about the ways that we can define the lesion, and this can either be done manually, which is the gold standard approach for defining where the lesion is within the ovary, or it can be done in an automated strategy using a deep learning model. The purpose of this, when we're talking about a radiomics classification model, is really just to allow you to extract the radiomics features. Now, once the features have been extracted, then, as Chris highlighted with the pipeline, it's applying machine learning and feature reduction techniques to then establish a radiomics-based model that is capable, if you could click ahead, Chris, is looking at what the model output could be. And this is either thinking about classifying a mass, so what we are really interested in is thinking about triaging adnexal masses into low and high risk on the basis of potential of malignancy, but it could also be used to sub-classify specific adnexal masses. And there has been some other work looking at different sub-classifications of adnexal masses, because that can help feed into other models that are already established. So, thinking about model performance, as we've talked about, the initial step is really saying, okay, how good is the segmentation deep learning model at picking up where the lesion is within the ovary? And effectively, as we know with regards to segmentation, it's essentially just a measure of overlap between the predicted, i.e. what the model thinks the lesion is, and what we think the lesion is. And you can see here that that there's pretty good overlap between the predicted and the ground truth. And what we're really interested in is actually working out how good does it have to be to still get the same output in terms of the classification. So even if you don't have a perfect dice score, i.e. the measure of overlap, which is 1 is perfect, can you actually still work out if it's a cancer or not on the basis of say, an automated segmentation pathway, which may not be as good as an expert? So that's the segmentation performance and the metric that we look at. And then when we're thinking about overall the model performance, when we're thinking at radiomics, it's about establishing what is the ground truth. So we have done a lot of work into understanding or kind of setting the standards for what we define as the ground truth. Now, the reason why this is important is largely because of avoiding skewed data sets. So one of the issues we have is that if we only select ultrasound images that were operated on, you're essentially sub-selecting a group of patients that have, by definition, a higher risk mass, i.e. a mass that may be over 7 centimetres, or might have slightly abnormal or suspicious features that then prompts the clinician to recommend surgical management. So to try and tackle this and give a fair assessment of models and saying, okay, if we're thinking about all masses in the community, we need to have a model that can actually look at all masses and give a good, and is able to classify them appropriately. So with that in mind, we actually used both histology, which is for all cancers had histologically linked, but we also used an ultrasound-based diagnosis as the ground truth. And we put kind of specific parameters in mind, that they had to have been reviewed twice and had been stable in morphological appearance to be confident in saying that over a period of expectant management, the cyst remained the same, to give us confidence in saying that this is likely to be a benign mass. And that is widely accepted within the kind of adnexal mass ultrasound evidence-based medicine, and is what we use to try and think about a real world model rather than those that is not actually going to work practically. And then clearly it's about what do we define, what is the desired model output? So is it, yes, benign versus malignant? Is that what our strategy is? Or do we want to know about specific adnexal mass subtypes that may help in further classification? So there have been various studies looking at radiomics. So looking at the next slide, there is a study that's been done from Italy. Not large studies looking at radiomics. So we were one of the first groups to really look at an end-to-end approach, but just highlighting some other work in the field where they've used radiomics to help sub-categorize certain masses. So there are nomenclature which we use to describe masses to be consistent with reporting, and they were able to identify kind of subgroups of masses and divide it into these various categories with various quite good performance indicators. But we have to be pretty cautious when looking at these, because these are all internal test sets and have not been externally validated. And they then went on to look at other aspects of integrating other clinical parameters to see if it overall improved the model using CA125 metrics in addition to the radiomics features. And there was seemingly an improvement in performance. And then again, an Italian group with a larger data set looked at looking at radiomics comparison to ADNEX. Now, if you're not familiar, ADNEX is the best performing model that exists, and is currently it's gone through a process of rigorous CE marking that is now sadly or positive. I don't know necessarily how to comment on this at this stage, but there now is a need to clearly have a robust structure for introducing models that are in clinical practice. And ADNEX has been externally validated in multiple different populations and had consistently good performance. And Francesca Morrow did not demonstrate that the radiomics model was superior. So actually, as it stands, the existing models that have been published hasn't really shown that it's better than what we have already with regards to clinical models. So that's kind of looking at previous work in the field, and we then thought, okay, can we use radiomics and deep learning to try and integrate machine learning from the outset? So can we use it to get where the lesion is in the ovary? And can we then facilitate the extraction of radiomics features to enable us to say, okay, is this likely to be benign or is it likely to be malignant, and help with that clinical decision-making process? So we used a development data set from Imperial, and this was just under 600 women and 1,400 images. So we used more than one image per patient. And they were all 2D grayscale images without calipers or any color Doppler. And as I said, they had an ultrasound based or a histology depending on the underlying diagnosis. We had a malignancy rate 23%, which you might, which is not typical. So that nearly a quarter of masses are not cancers, clearly, but we are in a tertiary centre, so we have a higher proportion of malignancies within our data set than you might find in a low risk setting. And then we collaborated with a group from Italy. So Professor Savelli provided a fantastic external test set that looked at about just over 180 patients and about 486 images. And again, they used 2D images and all were grayscale. But this time they used all histology, and they had a slightly higher malignance rate as a result of that. So that is just demonstrating the development data set and then an external validation set. So then moving on to looking at performance. So the first step of the end-to-end model is working out how good is that deep learning model at working out where the lesion is. So as we talked about earlier, we're looking at overlap metrics, and this is the DICE score. And Chris looked at various different segmentation models. And within the external validation set, the best performing model was the MANET, multi-attention network. And that gave us the best DICE score of 0.85, which is really pretty good, considering that, in validation, it's not a huge drop off, which again is reassuring when thinking about a model performing in a real world data set. So perform well in an unseen external test set. So that's how good it is at picking up where the lesion is and defining it in comparison to what I said the lesion was, checked by an expert. So then coming on to the model, how did it actually perform? So we looked at 3,906 radiomics features. Chris performed a very systematic approach to working out which was the best model. And this used, he looked at 11 machine learning techniques and 8 feature reduction techniques, and worked out which gave us the best combination and gave us the best performing model with various combinations, and you can see that in the heat map. So this then gave us, in the end, a final number of features that then fed into the radiomics classification model. And as you know, the whole purpose of this is trying to work out which are the features that are important in driving a malignant diagnosis and removing highly correlated features to create a model that not only performs well, but does not have a tendency towards overfitting, and therefore has better applicability and generalizability to a real world data set. So then this just highlights some of the features that are really driving malignant diagnosis within the radiomics cohort. And you can see here that there is a tendency towards features with non-uniformity in the title, i.e. heterogeneity, and that was the overall pattern that we identified within the features associated with malignancy, that they tended to indicate heterogeneity, which is what you'd expect when you're thinking about a clinical evaluation of a mass, that it doesn't look regular, it looks heterogeneous, rather than a mass that is benign that tends to look homogeneous and regular. So how did it perform within the Italian external validation set? So as Chris said, we not only looked at radiomics as part of the end-to-end model, we also looked at radiomics from the outset. So how good was a radiomics-based model looking at ResNet at working out what is the classification? So what is it a cancer or not based on that? And you can see here that directly comparing radiomics to deep learning, the radiomics outperformed the deep learning model across all of the metrics. And we were really, we weren't surprised, were we, Chris? But we were quite pleasantly hopeful about its overall performance, particularly thinking about cancer detection, because what we thought about this as a model that has value would be one that is able to quite confidently identify masses that could be malignant. And actually, within our data set, in this external validation set, we didn't miss any cancers, which, of course, we had an overcall rate, and that resulted in a number of patients prompting them to have further investigation, but we didn't categorize those with a cancer as being low risk, which is really important when thinking about a triage tool. And I think the radiomics-based models versus ResNet really outperformed on the basis of the metrics, partly because this is small clinical data sets. So, we're talking about 577 patients this is developed on. So it's not thousands and thousands of patients. So therefore, radiomics seems to be slightly better in these complex, smaller clinical data sets that are used in the development. So then this is just highlighting the radiomics model just individually, not in comparison to the other models. But you can see, as we talked about, very good performance indicators. So then we went on to say, okay, so how does this data set actually, how does the model work prospectively, and how does it compare to what we do already? So I've already mentioned one strategy for classifying masses that can be used in clinical practice. It is now CE marked, which is ADNEX. Now, ADNEX is essentially a model that uses clinical parameters, but also ultrasound-based features to give you an output, which is a percentage risk of malignancy. Now, ADNEX is fantastic. As I said, it performs very well. But what it relies upon is clinical knowledge to assess the mass and identify features and input that into a model. So it does require expertise. So what we did is we compared the end-to-end model, so using deep learning for segmentation and a radiomics-based model for classification, and worked out how does it compare in a head-to-head prospective validation data set in comparison to the ADNEX model. We also use simple rules, largely because simple rules is within UK clinical guidance, although is largely being replaced by ADNEX due to its superior performance. But you can see here that within the Imperial prospective test set, that the ODS model outperforms ADNEX both with and without CA125, which is a tumour marker used to help risk stratify individuals with the mass. And it gave again a promising classification performance. What we did say that we did notice a slightly drop in the pickup of the cancers versus the perfect recall of 1 in the external validation in Italy. But certainly this model, which does not require expertise, i.e. it's an automated end-to-end, so the model picks up the lesion, it extracts the features, it gives an output, in comparison to a model which, as I said, requires quite significant ultrasound expertise to apply it accurately. So it's definitely highlighting a potentially promising approach for classifying adnexal masses without the need for an expert. But clearly this is an internal validation set, so needs further evaluation in an external prospective test set. And then finally, just something to touch on, which is using radiomics in subgroups of patients. So we talked about the promise of radiomics based on our both retrospective and prospective validation sets. Now, radiomics, we think, may help us to differentiate between specific masses that are quite tricky to diagnose. You can run the next tab, Chris. So in pregnancy, one of the issues is that there's a process is called decidulization. Now, this is a phenomenon that happens related to the hormone changes that happen in pregnancy. And women with a benign mass at the beginning of pregnancy can undergo these quite specific changes to pregnancy and can have appearances suggestive of a malignancy, and can make patients and also clinicians quite anxious about expectant management because of the concern about an underlying borderline or clear cell cancer. So that results in some patients undergoing surgery in pregnancy, which you can understand have risks both for the mother and also for the developing fetus. So we looked at a subset of these masses. So we looked at masses with a solid component and did a manual segmentation of the lesions, extracted the radiomics features, and then ran a univariate and multivariate logistic regression to work out, is there a difference in radiomics features patterns between those with a benign mass, so a decidualized endometrioma undergoing physiological changes, or a borderline, so a malignant process within pregnancy. And actually what we did identify is that does appear to be a difference between the features between those that have a benign and a malignant mass. Now, this is a small data set, as you can see. It's 36 patients. So we are now undergoing a proper pilot study looking at if radiomics features really can have value within this subset of patients to help support masses being managed appropriately in a high-risk patient group. So then really just to summarize, so radiomics within an AI diagnostic pipeline. So the benefit really is that it offers a degree of explainability to the model output, because as I said, radiomics features indicating non-uniformity can actually be very helpful in understanding that's likely to be true on the basis that we agree that heterogeneity is a feature of a malignant mass. It does appear to perform well in a small clinical data set and outperforms a deep learning model in the same data set. We use multiple ultrasound systems to try and create a model that is built on a heterogeneous data set that then hopefully it performs well across other data sets in the future. And as we've highlighted, external validation, as we know, is really important to evaluating a model to know its performance. Our aim, of course, is always to facilitate or to hope and collaboration with other groups to facilitate open sourcing of not only the code, but also to the data sets to allow head-to-head comparison of various models on different data sets to truly work out how they compare. And finally, how do we get this into clinical practice? So yes, this has demonstrated value, but how do you go from dry lab into clinical integration in a safe, but also without having a 10-year lead in that then means that this is not going to really help patients clinically. Thank you very much for listening, and really look forward to your questions. And this is clearly not the work of two people. This is a wide collaborative team, and these are just some of the names mentioned here.
Thank you very much, Jen and Kristofer. This was fascinating. I have a million questions already, but I think we need to carry on with the second talk and come back to your presentation with questions at the end. Thank you.
Yeah, thank you indeed, Jen and Chris. That was amazing. I'd like to introduce the second speaker of today, and then we will move to Q&A at the end. So our second speaker is Dr. Simon Laws. There. Hi, Simon. I will try to introduce Simon. He's got lots of titles, so it's going to take me a couple of minutes. But Simon is a consultant breast radiologist at Gateshead Breast Unit, but is also the director of the newly opened Northern Center for Breast Research. Other than his clinical role, Simon is also honorary clinical senior lecturer at Newcastle University, research lead for the School of Radiology across the Northeast and North Cumbria. And he has lots of nationally appointed roles, including executive committee officer of the British Society of Breast Radiology, and membership of the NICE Breast Cancer Committee, as well as the RCR Academic Committee and NIHR Imaging Group. And finally, last but not least, recently, Simon has been named the Royal College of Radiologists Röntgen Professor for 2026, which is great. So with that, I'd like just to leave the floor to Simon. Thanks, thank you again, and look forward to hearing about your work in AI for breast cancer.
Thanks, Annalisa. I'll just make an attempt to share my screen now. Work. Can you all see that as my presentation?
Not yet, but we can try one.
Fine, just give me a sec.
Yes, it's coming through.
Great.
And then if you want to make it full screen.
Is that slideshow showing now or not, or is it?
Yes, it is.
Yes, now, yeah.
Great. Thank you very much. Yeah, so thanks again, Annalisa, and Bianca as well for asking me to talk. So unlike my predecessors on this session, I'm not an expert in AI as such. I do a lot of research, but I'm not an AI expert. But what I'd like to talk to you about is how AI is likely to be able to fit into our clinical pathways from the perspective of a breast radiologist, a breast clinician. So it probably helps to give you an overview of our breast care pathways currently. There are two main ways that patients enter into our system: via the breast screening route through the NHS breast screening programme and via the symptomatic route. So as a radiologist, it's my role to interpret imaging, so diagnostic imaging, which comprises mammography, ultrasound, which we do, and we do ultrasound guided biopsies as well, and minimally invasive interventions such as removing small breast cancers in the context of research, also needle guided biopsies and localizations as well. We do MRI interpretation and contrast mammography as well. We have a very multidisciplinary approach with breast care. We have contact with the patients from pre-diagnosis all the way through the whole pathway, and work very closely with surgeons, oncologists and pathologists. So breast screening is accounts for a large volume of our work, not so much a large amount of our time, but a large volume of our work. And there are two main outcomes when we review mammograms, and I'll talk about this on the next slide in a little bit more detail. But one is if the mammograms are normal, then we assign the patient to routine recall, and that means they get a letter reassuring them that everything's normal and they'll be invited again in 3 years' time. The other option is that we find an abnormality on the mammograms and we recall the patient to a clinic for further assessment, and these are called assessment clinics. At that point, we do additional imaging. So we normally do additional mammograms to give us further clarification of that change on the screening mammogram, and we do an ultrasound scan as well. Very often, we find that after these additional imaging tests, the findings are normal or benign in nature, in which case we can reassure the patient, and again, they'll go to routine recall. If there are indeterminate or suspicious findings, we then proceed to a biopsy, and that can be done one of two ways, either using ultrasound to guide us if the abnormality is visible on the ultrasound, or if it's only visible on the mammograms, then we can do a mammographic or stereotactic guided biopsy. And there are two outcomes of this: either it's benign, in which case we can reassure the patient and they can be discharged, or it turns out to be a malignancy, in which case we refer the patient to a breast surgeon. The second route into our service is via the symptomatic pathways. These are GP referrals to our 2-week wait one-stop clinics. So patients present with a variety of different breast symptoms to GPs, and we see them in clinic and give them a triple assessment. So initially they'll have a clinical history and examination by a member of the surgical team. If at that point it's deemed appropriate for the patient to have imaging, which is the vast majority of our patients in practice, the patient will then go on to have normally an ultrasound scan, and if the patient's 40 or older, they'll have mammograms as well. And again, if things are normal or benign, which accounts for the majority of our patients in symptomatic clinics, we can reassure and discharge. And if they have an indeterminate or suspicious finding, once again, they can have a biopsy with either benign or malignant findings, in which case, if it's malignant, the surgeon will then carry on their management. So to tell you a little bit more about that screening pathway, because this is where AI, at least in the next few years, is most likely to integrate into our clinical practice most, we have 2 views of each breast for each patient. So that's 4 mammograms to review. If that patient has attended before, then obviously we'll have a prior mammograms to compare it against. Each set of mammograms is double read, so 2 either consultant breast radiologists or 2 reporting radiographers trained in mammographic screening will look at the mammograms independently of one another. If they both agree that everything's normal, then the patient will go to routine recall. If one of the readers or both readers agree that there's an abnormality on one of the mammograms, then it goes to another step, which is arbitration. So either a third reader or ideally a team of experienced readers will then review those abnormal mammograms and decide whether it's appropriate to push that patient back to routine recall, or whether they need to come back to one of our assessment clinics. So currently, breast screening, when it's done by humans, how does it perform? Well, around 3% of women are recalled from the screening program. Around half of those will have a biopsy in clinic. The rest will be discharged. And 8 of those 15, so 8 per 1,000 women, will end up having a cancer detected. And this is fairly consistent. It does vary a little bit depending on centres, and these are UK statistics, and it varies a little bit from screening program to screening program across the world. But of course, screening doesn't work all of the time. We know there are problems, and we always advise patients that breast screening doesn't detect all breast cancers, which is why we encourage all women to be breast aware. And we know it doesn't work because we get interval cancers. And these are cancers that present between screens. They typically present via that symptomatic pathway when the woman notices a lump. And the interval cancer rate varies a lot, again, between centres and between countries. But across the UK, it's estimated, certainly in 2023-24, at around 3 per 1,000 women. And what's important about these is that when a woman presents with an interval cancer, it has a poorer outcome than if it was screen detected. With every interval cancer we get, we do an interval cancer review. So every now and again, we'll collect our interval cancers, and we'll have a larger team review of these. We'll independently look at that initial screening mammogram before the interval cancer presented, and then we'll get together as a consensus and decide whether we could have detected that breast cancer in hindsight at the time of that screen. When we do that, around 80% of breast cancers were found not to be detectable at that screen. So either they hadn't developed at that point, and it was reasonable, therefore, not to recall them, or they were mammographically occult. The other 20%, 13% overall, had some changes in hindsight. So these are features on the mammogram that were eventually, they resulted in development of that cancer, but they weren't necessarily suspicious enough for us to recall that woman. And 7% of all our interval cancers, in hindsight, did have some suspicious features and probably should have been recalled. And again, these aren't our local statistics. These are based on the National Breast Screening Programme from 23 to 24. So when we're thinking about AI and we're thinking about breast screening, how can that help us? Because we're reasonably good as humans at identifying abnormalities and deciding whether they're suspicious or not and warrant recall. So, for example, this is a mammogram on the left of a left breast of a lady in 2020. Mammograms generally are, most of the breast tissue is a dark grey colour, which is fat, and the cloudy, darker, denser material is the glandular tissue. And every woman's breast tissue is different in terms of the amount of fat versus the glandular tissue, in other words, the breast density. So this lady in 2023 had a new abnormality, which is easy to spot because it's there within the fatty tissue, and that turned out to be a grade 1 invasive ductal carcinoma. And these cancers actually are fairly indolent generally, and I've shown this example on the right just because it's quite a nice one, slightly removed from AI, but she's part of a trial called the SMALL trial, where we're moving away now with low-grade, fairly indolent, small screen-detected breast cancers, and they can be randomized as part of this SMALL trial, either to have conventional surgery to treat this cancer or to ultrasound-guided, minimally invasive vacuum-assisted excision using local anesthetic. And so this is a tumor excised in 2023 after diagnosis, and this is a 2025 follow-up showing that the cancer has not returned. So as well as spotting nice things that are kind of fairly obvious within fat, we're also pretty good at spotting subtle signs. And this is actually a case earlier this week that I thought I'd show just because it was a really good pickup, I thought, by one of my colleagues. So these are screening mammograms on the left from 2022. So we do 2 views of the right breast. One is basically looking at the breast from the side. The other one is looking at the breast from the top. And this woman has fairly dense glandular tissue, so it's very difficult to spot abnormalities within that, one of the potential pitfalls of screening mammography. But there's a tiny little area just at the top of the breast, which I'm indicating with the mouse pointer, and I'm going to highlight it with a circle in a second, a really subtle little increased opacification, which when recalled from the screening program turned out to be a grade 2 breast cancer. So a really good spot. So we are pretty good at humans at spotting these subtle signs as well, but not perfect. So as mentioned, humans are okay, but we do undercall because we know that through the interval cancer process, and we do overcall as well. So we have a fairly low threshold for bringing women back from the screening program. anything that's changed that we can't fully assign as being benign, then we'll bring them back. But we result in lots of false positives as well. And our overall performance as humans is limited by a huge number of different factors: our experience, our skill, distractions, which are really common, and fatigue as well through being overworked, like all clinicians. And also biologically, our perception is inherently limited. So there are all sorts of perception illusions that are fairly well known, such as this one, the inset bar. The question, is it darker on the right or on the left? In actual fact, when you crop out the bar, it's just one shade of grey. But our brains tell us that it's a gradient bar, but a computer could tell us instantly that this is just one shade of grey. Similarly, another well-known illusion: these horizontal lines, are they curved or straight? Well, they look curved to the human eye, but if we draw a grid across them, they are in fact straight. And similarly, this Ponzo illusion, these two horizontal blue bars, which is the longer one? Well, our brain tells us that it's the top one that's longer, but if we draw vertical lines through it, we can see that they're both the same length. And once again, computers can tell us this answer fairly quickly, but our brains tell us otherwise. So AI could help us with those things, with our diagnostic accuracy. But the other thing about breast services across the whole country is that we're chronically overloaded. We have workforce shortages for radiologists, radiographers, breast surgeons as well. And we have a continually increasing workload as well. So we need a way to try and help us. So can AI identify those subtle signs that we're not able to perceive with our eyes? So one example here is another woman with very dense breasts. She presented to a symptomatic clinic with a lump in the lower half of the breast around this area, which turned out to be a breast cancer. I'm going to zoom on that little area because there are some very subtle features as I move my mouse pointer around this little area that suggest that there's a little area that's different from the glandular breast tissue. Really subtle sign, and I've highlighted it with some arrows. But this is what we call a mammographically occult breast cancer. Effectively, yes, there might be some signs that will direct us to a change, but realistically, a human being is not going to be able to perceive that. What we do with mammographically occult breast cancers is we do other imaging tests. I mean, this cancer was identified on the ultrasound scan. That's ultimately how we found it. But we tend to do another imaging modality just so we've got two modalities where we can confidently see that breast cancer to make sure it's unifocal, so there's only one of them in the breast, and that we can see it and size it accurately. So in this case, we did contrast enhanced mammography. So this is when we do mammograms, but we give intravenous contrast agent. It's an iodinated contrast, similar to what we do for a CT scan. And this basically strips away all of the background breast tissue and leaves behind the enhancing tumor. And this shows, again, it correlates with that little area in the lower half. Is this something AI could then be able to detect at the time of screening? And another example is this lady who, there's an arrow pointing under the nipple area to an area where on ultrasound she had a little area that turned out to be a breast cancer, but once again, we couldn't see it on mammography, so we did contrast enhanced mammograms. At the same time, there's all sorts of changes going on within this glandular tissue. It looks fairly typical for glandular tissue, but there was a little area up here in hindsight, and I've zoomed up so you can see it a little bit more clearly. This is an area that's fairly well defined. It was probably just dismissed as benign change because benign lumps and bumps like fibroadenomas and breast cysts, super common. They typically have these fairly smooth features. But when we did the contrast enhanced mammograms to look at this area under the nipple more, admittedly, we didn't see a whole lot under the nipple area, but this little area enhanced, which is typically what tumors do because they've got increased vascularity, and so the contrast preferentially enhances this little area, and this turned out to be a little breast cancer as well. So would AI be able to perceive that as something that was suspicious that human perception couldn't have done? So if we're going to use AI techniques, we need to make sure that it's a benefit. So what ideally we want is at that time of screening for it to increase our cancer detection rate, to overall reduce our recall rate. Yes, we want it to increase the number of cancers we bring back, but ideally we want it to reduce the number of false positives. So we want it to increase our positive predictive value. And hopefully in doing that, we'll reduce our interval cancer rate. And there are a huge number of studies now on AI. using a variety of different approaches to breast screening, using retrospective, prospective studies, using a variety of different vendors. But they all give us a lot of promise in terms of integrating them into our system. A lot of work comes from Scandinavia, and this was a retrospective study using AI to look at interval cancers. And they applied the AI tool and found that if they were to use that in clinical practice, they would have detected nearly 20% of their interval cancers, particularly those that show those very subtle signs, not necessarily suspicious, but subtle signs of malignancy. However, the AI actually regarded those as high risk. And there were prospective studies again, and once more, this is another study from Sweden, and they looked at comparing standard 2 radiologists reporting screening mammograms versus 1 radiologist plus AI, and they found non-inferiority, but actually a small 4% increase in the cancer detection rate. And there are loads of these things. This is another randomized study from Sweden that found a 29% increase in cancer detection with 1 radiologist reader plus AI compared to standard double reading without AI. The false positive rate was fairly similar using this particular AI, but they did find a 44% reduction in screen and reading workload. So it ticks both of those boxes in terms of finding more cancers and reducing our workload. So the various different ways we can potentially use AI, we can use it as an additional third reader, and the previous study used that as one of their arms, but that's not necessarily going to reduce our workload because you've still got 2 readers employed to do that screen reading. Where it seems most helpful will be either to use as a replacement second reader, so we get that increased cancer detection, that increased PPV, but we lower the workload on our service, or potentially as a triage tool, so we get rid of all the obviously normal mammograms through AI, and then we look at the more challenging, indeterminate, complex ones, either as 2 human readers or as a human reader plus AI. One of the real challenges, though, is we need a real-life study, and particularly across the UK, there are lots of these smaller studies, and some centres have adopted AI, but there's a lot of lack of validation of AI tools at the moment. So you may have heard about the EDITH study, the Early Detection Using Information Technology in Health study, which is funded by a very large NIHR grant led by Professor Sean Taylor-Phillips and Fiona Gilbert, which is going to involve 30 sites across the UK and nearly 700,000 women to look at various different aspects of AI and breast screening in a lot of detail using analysis of a lot of different parameters. It's going to be a multi-vendor study using different AI systems, using different PACS systems, which are the systems that we use to view our images, and of course different mammography equipment as well, because there's a lot of variation across the country. And it's going to investigate AI as an independent reader or as a triage tool, which I alluded to earlier. That's still being set up at the moment, and we're keeping our eyes and ears open for when expressions of interest will come to the different sites, but that's taken a little bit of a while to get set up. It's logistically going to be a huge, huge challenge, but hopefully it's going to be able to pave the way for us to introduce AI into our clinical pathways in the future. And there are other ways to incorporate AI into our breast care pathway beyond that of screening mammograms. We heard earlier very eloquently and in a lot of detail about radiomics, and there's been, just like AI, a massive explosion in the number of publications on radiomics in the past few years, a lot of interest in it, in breast cancer included. And as described, it involves looking at features of imaging, in this case breast imaging, breast cancers, and looking at regions of interest and using deep learning techniques to develop signatures and to correlate that with molecular characteristics and the biological behavior of tumors. And so this one day hopefully may allow us to look at our cancers with a great deal more confidence on our screening mammograms, for example, give us some diagnostic predictions even before we recall women, not just saying that they're suspicious or not, but actually giving us much better biological information, so we can maybe stratify the priorities in terms of bringing women back from screening, or even stratify screening in the future. And it can be used in other ways as well. And one of the projects we've started to work on with Professor Occhipinti is looking at, can we predict response to neoadjuvant chemotherapy? So I talked about our breast cancer pathway earlier, and we got to the point where we did a biopsy, we found the cancer, and we refer it to a surgeon. Most women, when they have a breast cancer diagnosed, will have surgery as a primary treatment to excise that cancer. But some women have other treatments as well before they have surgery. And a small proportion of our women will have chemotherapy over a period of months. And this was traditionally done to downstage disease when we found breast cancer at a later stage. So big, more advanced tumors with heavy axillary nodal burden would have neoadjuvant chemotherapy to downstage that tumor and the axillary disease before surgery. But now we're using neoadjuvant chemotherapy in a greater proportion of cases now that we know much more about the biological behavior of different tumors, and we have targeted treatments to treat those tumors. So sometimes very small tumors now get treated with neoadjuvant chemotherapy if they're triple negative breast cancers, for example, or HER2 positives. And that's not just downstaging, that's because it gives them an opportunity to have systemic treatment before surgery, but it also gives us an idea about the chemosensitivity of those tumors if they're going to have adjuvant chemotherapy after surgery as well. Because what we can do is we can monitor that response of that tumor to treatment using imaging. And one way we do that is using MRI. So on the top left here, we've got an MRI image of a patient with a large tumor in her right breast. And below that, we've got the images of the tumors using contrast-enhanced mammography as well. And in the middle, on the bottom, is an ultrasound image of that same tumor. So these are the things we're hoping to extract the radiomic features from, and we will be able to then correlate that with how that patient responds to neoadjuvant chemotherapy. So on the right-hand side are the images of that patient's breasts with mammography and contrast-enhanced mammography after she's completed her neoadjuvant chemotherapy. And in this case, the tumor has completely disappeared, so she's had a complete radiological response. Not all women have a complete radiological response. Some will respond poorly, so have either a partial response, or they may even progress to neoadjuvant chemotherapy. But by using these data sets, hopefully we'll be able to get a better idea of the features that will predict the response to neoadjuvant chemotherapy. So that's a whistle-stop tour. I'm more than happy to answer any questions, and thank you again for asking me.
Thank you. Thanks a lot, Simon. I think there have been lots of interesting discussion points in this presentation and as well as in Jen's presentation. I'm conscious of time, but I can also see that most people are still around. So we still have 60 people online. So if that's okay with both speakers, and if Chris is still around as well, we can keep a bit longer, so we can stay a couple more minutes and then start with the Q&A. Jen, is that okay with you and Simon?
Yeah, that's fine. I have a clinic, but I can stay definitely for a few questions.
All right, thank you. So let Kristin lead the Q&A, and you can see there's another question for Simon.
Okay, great. Thank you so much. I can't see the questions in the chat currently. Lisa, can you see them?
Happy to ask a question for both of you. There's one, yeah.
Here we go. Yeah. Okay, perfect. Thank you both so much. These talks were amazing. So the question was, why did you not include color Doppler in the initial Imperial data set of 577 patients?
It's a really good question. The reason why we didn't is that we couldn't remove the color Doppler from the images once they've been extracted. So the concern is that, as you know, that it's not just the color Doppler that you can see over an image, but you can also see the gate, so the green gate that indicates the field that you're assessing for vascularity within the mass. So they're the two issues. And the third issue is, although we have standardization in terms of PRFs that we scan at, there still are various other variations in settings that people scan with that then could impact on the information that have been taken from the color Doppler, and that's not been standardized or controlled for within each image. Now, it's not something that we are ruling out, and this is in part of the second part of our work. We're now looking into using colour Doppler images because, particularly for certain masses, it's incredibly helpful to evaluate the vascularity within a mass as part of information of determining whether it's a cancer or not. So we're not giving the machine all of the information that we have to evaluate a mass. So it's certainly something that we are looking into, but there's a few variables that we need to control for to allow it to be fair in terms of the information extracted.
That's great. Do we have any other questions from the chat? If you have a question, you can put it in. You could also raise your hand. Bianca has put a question in as well, but I'll go to Carolina, who has her hand raised.
Hi. Yes. Yes, I had a question just for Jen and for Kristofer. I think I might have missed it. So could you give a couple of examples of the radiomics? So are the radiomics that you used more intensity related, so the image intensity related, or they're more shape features? And if they are, could you give just a couple of examples to have a better idea of what you did? And also then so you took those radiomic features and then put it like just in a statistical model or in a machine learning model? I don't think I got that. So if you could just clarify.
Yeah, good question. So we extract just over 3,900 radiomics features. So think of these radiomics features as just statistics that you can pull out from the image pixel intensities themselves. The most basics being sort of mean pixel intensity, median, 75th, 25th percentile, etc. And we also extract shape features. So it's not one or the other. We extract both. And that's what essentially starts to comprise this massive tabular data set of 3,900 features. They get more complicated. Those were just really kind of simple examples that we can all identify with, but we can do filters on top of the image. So imagine putting a filter that makes the image more dimmer, but you get higher contrast and things like that. You put these mathematical filters called wavelet transforms and fractal transforms on top. And then once we have this big tabular data set, so each column would be one of these 3,900 features, and each row would correspond to an image or a patient. We then implement our machine learning protocol. The machine learning you generally, because you've got so many features and less patients, you want to reduce the dimensionality of your data. If you have lots of features and you start trying to put your machine learning models on them straight away, you're going to run into problems like overfitting. So you'll get really great model on your training in-house data set, but it won't generalize too well to any external data sets. So that's why we do feature reduction as the first protocol. Feature reduction can basically be trying to remove features that are highly correlated with each other, or features that have zero variance, things like that. We cover a big sort of programmatic list of feature reduction techniques. And in parallel to that, once we do the feature reduction, we're reducing down to a few hundred features or less. We then aim to do our machine learning models. And those are like things like your random forests, linear models, logistic regression, but also more complicated models. And it really depends on what outcome you're looking at. For instance, the prognosis study versus the Nexo mass classification study, you're doing different types of machine learning, one being binary classification, the second being prognosis. So that was survival models. Yeah, I hope that answers your question.
Yeah, that does. I had another, but I think there is a lot on the chat, so you go, and then if we have time, I'll come back.
Thanks so much. Yeah, so we'll go to the next question that was put in the chat. So it was a question for Simon. If we want to integrate AI into the breast cancer diagnosis pathway, beyond improving AI accuracy, what other aspects of the healthcare system need to be considered to ensure AI can be smoothly embedded into clinical practice?
Yeah, well, there are lots of challenges in doing that. And I think the Edith study will identify a lot of the barriers that we're going to face in trying to do that. The fact that Edith's study hasn't launched yet, I think, reflects some of the huge challenges that we're going to face, mainly through the IT elements of it, how that's actually going to work. But there are other things to think about as well. I mean, I talked about workload, and that is an important consideration, but in actual fact, the amount of screen reading we do as breast radiologists is relatively small compared to all of the other tasks that we do. We're a very hands-on specialty, so we are required as humans to interact with patients a lot and do image-guided procedures. One of the things we need to bear in mind is if we integrate AI too much and have just one reader who's reading, we have requirements ourselves to be able to have to report a certain number of screening mammograms per year, so we can maintain our skills as well. And one of the risks is that we will de-skill ourselves and actually end up with not enough work for us to do as radiologists. And that's not being protectionist over our domain, because, as I say, we've got huge amounts of work, far much more than we can manage. It's just about maintaining that skill set as well. So I think that's going to be one particular challenge to consider. I think as radiologists, we will, and reporting radiographers will try and defend that ourselves. But when it comes to looking at workflow from a management point of view, we may have a little bit of a fight on our hands in the future.
Can I just say something just towards that, Simon? Because I think one of the issues that we have in the health service is this breadth of skills and the ability to maintain some skills that actually are not being used on a relatively frequent basis. So therefore, the risk, of course, is becoming de-skilled. And I wonder whether there is an element of saying that it may allow clinicians to subspecialize into certain aspects of a specific job, and then allow, provided the AI tools are able to deliver on what they say they can do, and that replace certain aspects of some clinicians' jobs, but then have some radiologists that still remain in that role. I don't know whether you think that might be a solution in terms of just trying to keep everyone with the bare minimum of screening per year.
You're on mute, Simon.
I clicked the button, but obviously it didn't work. So yeah, across the board as radiologists, I mean, we have a 30% chronic workforce shortage with increasing demand, and that's across all subspecialty areas. And breast is no different. Breast is probably one of the areas that struggles the most as well. So we need to find ways to try and do that, and actually, for want of a better term, sort of siphon off the stuff that we don't need that subspecialist input into. And then we can concentrate our efforts on that complexity, because you'll know yourself, what we do now is much more complex in every specialty than we used to do, as we have better ways to manage conditions. We know more about the science behind things, more about the complexities of imaging. We need to concentrate ourselves a little bit better on the things that require all those years of training and that subspecialist interest. So I think there's definitely something to be said for that within breast imaging as well, whether it's using these AI approaches, which I think will be really helpful for minimally invasive diagnosis and prognostication, and then to free us up, because we're always going to be needed as clinicians, and to have that, well, I hope, and to have that level of subspecialist interest. And I find that a lot of what I do is dealing with normal stuff, which I don't want to underestimate that as well. So it's really important to be able to identify normal and stratify it and reassure accordingly.
Yeah.
But a lot of that more complex work, that needs a lot more time and dedication, that I really struggle to find the time for.
I just want to be conscious of time. Do we have time for one more question?
We have one more question, then I'm gonna have to run.
Perfect. I don't want to keep you hostage.
Similarly as well, someone was trying to get me to come to the clinic a second.
Okay, so we'll have one more question, which is, apart from AI helping in cancer detection, will it also help in treatment? Or are you considering it in future research?
Yeah, I mean, the really interesting thing, and we haven't really touched on it, well, Chris did touch on it in relation to some of the work with CT about looking at the genomics profiles of patients with radiomics features attached. So what, in theory, you can do is looking at an image and be able to tell a patient about what is the specific treatment that's targeted for them based on their genomics profile, without having to do any invasive biopsying. Now, clearly, that's a real something for the future in terms of projection, but it could have value in terms of subtyping patients into specific groups that we know will respond to certain drugs. I don't know if you've got anything to add on that, Chris.
Yeah, so there is a lot of work within the radiogenomics subdomain, where you can kind of correlate your radiomics features with different genomics outputs. You should look up work by Philip Lambin and Hugo Ertz. That was kind of the initial definition, showing you could, I think they could reconstruct something like 7 to 8% of genomics profiles using radiomics features, which was quite impressive. And then there's this other avenue as well, rather than your task being adnexal mass classification or prognosis, kind of what I think Simon mentioned is, responders to different chemotherapy as well, whether it's, different chemotherapy types, etc. And then in addition to that, the prognosis work, when you can start to identify people in those high and low risk groups and kind of come up with new ways to subtype them, you can sort of come up with theories of new or better ways to treat these individuals, whether it's a more aggressive chemotherapy early on for those that are in that unfortunately poor prognosis subgroup.
Great. Thank you all so much. These talks are amazing. And thank you all for the questions as well. It's been really, really interesting. I just want to mention we do have in March an event coming up for International Women's Day that's going to focus on advice for early career researchers. So that'll be more interactive sessions. So have a look out for that in your calendars. But thank you again, all of you, for joining today. We really appreciate it.